This is sort of an interesting twist on the work group. So now it's a few years running where we've had sort of a cadence, and just like the rest of the world, COVID has asked us to sort of take a detour left or right. But the work group itself is now zeroing in on aspects of the social determinants of health as one of the areas where it's worth drilling in and getting a little more knowledge as to how we can capture, access, and utilize that information to make a difference in healthcare. So in last year, we uncovered 5 different non-traditional types of data: genetic data, patient-reported outcomes, wearables, images, and social determinants. This year, there was so much interest in it, we decided to have several different meetings just on that topic. And some of the topics we're going to have include the role of health information exchanges in capturing and accessing social determinant data. Now, it's a brand new category of information for the medical industry, so we would have a session on how to categorize and codify that information so it can be used. We're on a journey to do so. It won't happen overnight. We'll have a session on the role of telehealth, remote monitoring, and patient-reported data on social determinants, and we're hoping to get University of Virginia for that one. They have some amazing programs. And how collaboratives align stakeholders to capture and utilize social determinants like the DISRIP program. And I don't know if you saw just yesterday, New York State, with all of its troubles, put another $2.7 billion into their DISRIP program, which is all about the social determinants of health. That's validation that it's not just a phrase, but rather it's where things are going. And if we have time, we'll dig into the policy and operational issues associated with surveillance and behavior. Let's go ahead. But we did take a turn left to address COVID. So I'm now going to take a slide out of a former presentation we had last year by the American Heart Association, and it was Patrick Dunn. And he identified, if you click again, Claudia, one click. The American Heart Association strategy and our task force is really way more aligned than we ever anticipated or thought. So for example, they're saying that changes and a strategy associated with science and discovery, translation, diagnosis, transitions, and at home can make a difference. Well, 2 of those 5 are right in the sweet spot of what this task force has been focused on for years. So 2 years ago, we did a lot of work on care transitions. Our work is not done, but if you click once, you can see that the improving transitions of care is absolutely critical to improve outcomes. And that is as patients go from hospitals to skilled nursing facilities, rehab, home health, we're losing information and a lot of problems occur. So we still need to continue to shore that up. And we had some good sessions on that and talking about the HIEs and emerging networks and the use of FHIR and some of the operational challenges. And there, we had some great best practices on that part of it. Now, last year, click again, we had some sessions on patient engagement and how telehealth, remote patient monitoring, et cetera, are able to make a difference. Today's presentation sort of brings them home as to how some of these are both happening and are going to happen even more in the future, but it's how we apply that data that will really make a difference. So one more click, and it is applying that for the population, whether it's the patient cohorts that have different needs and different abilities to use that data, or it's the ability to collaborate across organizations. The introduction, and Dr. Berlowitz will share, on evidence-based care plans. How do we identify the gaps, and then how do we really address that with some actions that make a difference? So our task force has struggled with some of these issues and had best practices in each of these. Today, you'll see reinforcement in cardiology. So with that, it is my pleasure to introduce, we can go to the next slide, Dr. Michael Berlitz, who, as Claudia said, Chief of Cardiovascular Operations and a business person as well as a cardiologist, and he'll share a story of how they were had to make change rapidly, and necessity is the mother of invention. So with that, Dr. Berlowitz, please tell us your story.
Thank you very much, Al. It's a pleasure to be on this webcast, and hopefully everybody can hear me. Maybe Al, if you just nod, I can see your picture and your gray beard. Yeah, perfect. Yeah. So, it's interesting, the idea of social determinants of healthcare. I mean, there's no bigger social determinant, I think, than COVID over the last few weeks. And it's, for us, the COVID crisis has been quite transformative. Transformative both in good ways and transformative also in lots of challenges and opportunities that have been difficult, but a journey that with some sweat, some hard work and rolling up sleeves, we were able to accomplish. And I'm happy to share a lot of that with you. The COVID crisis, we had to fast track major overhauls in processes and patient care. It certainly was without the standardized kind of approach or roadmap that we would all expect. It changed our perspective of not only what is possible, but how we can do things differently now and forever, probably. The other thing, before I kind of speak in my presentation, reimbursement defines everything. Cash is king. It wasn't when the governor and the president ordered that telehealth was going to be reimbursed that changed everything. When I look at, I'm involved in residence and fellowship training, and when I ask what the young doctors in training are going to go into, what are they going to apply to, what are they going to become a fellowship or subspecialize in, it's amazing how it correlates with the jobs that have the highest compensation. So telemedicine, telehealth right now is being reimbursed, and away we go. I'm going to tell you my story, and it'll be interesting to know what would happen if it wasn't. Let me have the next slide. So USF Health we're a large organization. We're here in Tampa, Florida. We're a large division that has actually really several important arms. We have the mission of academics. We have one of the largest medical schools in the country. The mission of research. We're very active and have a very large research organization, and certainly our clinical mission as well. We have CAMELS here, which is the Center for Advanced Learning and Simulation, which has worked with the AHA and with the Guidelines program in the past, as well as industry training for the American College of Cardiology, and I was a part of that. We have the USF Heart Institute, which is a modern research facility. I don't know if anyone on the panel here has been in downtown Tampa recently, but it's a brand new, beautiful building, 100,000 square feet, dedicated to translational research, headed by Dr. Sam Wickline from WashU St. Louis, and really works on bench to bedside. And we also have a large subspecialized clinical division. We have national expertise in neurocardiology, cardio-oncology, cardiovascular genetics. Next slide, please. So the impetus for change, it was rather immediate. On March 6th, CMS agreed to temporarily pay clinicians to provide telehealth services across the country. The reason that telehealth was never really a mainstream tool for healthcare was simply that it was not reimbursed. It was reimbursed through some directives earlier this decade based on need, based on supply of the healthcare in those areas, but it wasn't environmental wide. It wasn't for the standard care of our patients, and that changed in the beginning of March. On March 20th here in Tampa, all of our outpatient clinics were officially closed for business. No elective procedures, no in-person patient visits. Patients couldn't come to get evaluated. They couldn't get their ECGs, their echoes, their nuclear scans. They couldn't get any testing. It was closed. All emergent or urgent cases could be seen, but they were seen in an urgent care center or a part of the hospital that could help screen, test, and take care of the more emergent population. And we'll talk a little bit about that because there's some interesting anecdotes that we've learned with that story as well. So as the chief of operations, I had to change an entire division of how we do business to a telehealth business in one day. And it was a very atypical business plan. We had no time for traditional analysis and planning. The PDSA cycle, as we all know, is more of a DA cycle. It was do and act, and then we plan to study this afterwards. Next slide, please. We basically went through a running data-driven needs analysis, and these are just some of the items that we had to do rather quickly. And this is the flow of the telehealth patient visit that we had to standardize and functionalize within 24 to 48 hours. We had to understand virtual patient throughput, and I think that's the silver lining, was to really understand the process from a microscope that we never used before. The steps in patient flow had to be meticulously analyzed. For us, it was the first time that we went through this exercise, which I think became critical, and I recommend for all delivery of healthcare. We needed data to understand our needs and to make change. The process allowed us to recognize all of the stakeholders, the contacts of care, the details of throughput that really went unrecognized previously. And even if we go back to in-person visits, this exercise and process definition, I think it will improve our outcomes. It will certainly improve our efficiencies. And I think most importantly, it will improve our patient satisfaction. Next slide, please. The key for me as the chief of operations was to ensure that there were no gaps. I termed it the no gap strategy. I wanted it to be seamless, but I wanted no gaps in quality, no gaps in outcomes, and no gaps in patient satisfaction. I wanted to maintain a 60% of our patient volume that previously was in person, and I will tell you that we surpassed this rather quickly. Interestingly, another silver lining from this transformative piece was all the patient calls that we got every day. We dealt with, our call center probably dealt with between 300 and 500 patient calls on a daily basis. Many of those calls are clinical. They get routed to a nurse or a medical assistant. Some of those get triaged to the physician, and the provider will get to them maybe days later with an answer, and all of it is unreimbursed, and all of it really is suboptimal. The patient usually gets a limited amount of information back, and the physician or provider doesn't spend much time trying to answer the phone calls. Well, all of that transitioned to telemedicine. Now when a patient calls with questions regarding their medications, side effects, any issues that they were having at home, any anxieties, any worries, we just hook them up with a telemedicine visit. They're able to speak to a physician, and that call gets reimbursed, but everybody, the patient gets much better care. Now, to say this, in our initial studies, patient satisfaction has been extremely favorable, especially in that subset. And we're all predicting that a large subset of patients will prefer telemedicine over coming in for their in-person visits. To give you an example of scope, our charges in 6 weeks went from $0 the first 3 days to over $500,000 in just telehealth visits in 4 to 6 weeks. Next slide, please. So what's the future? Well, I think that everyone would agree, especially here at USF, our future clearly is to expand telehealth, which is in part likely here to stay in some respect, regardless of the reimbursement. I prefer the definition of telehealth as provided by the National Consortium of Telehealth Resource Centers, which was finalized in a telehealth definition framework. I think it was published in 2014. It's broad. It's the use of digital technologies to deliver medical care, including clinical care, health education, and monitoring, all with a broad range of communications. And for us, in cardiology, data collection that would be critical would be heart rates, blood pressure, pulse oximetry, and activity levels. home ECG monitoring, especially when patients are symptomatic, are all very important. And so we need to expand and try and develop the data gathering and the ability to monitor these patients, both with our monitoring systems as well as patient self-monitoring. Next slide, please. Now in cardiology, you can you can click it twice. I know it's a busy slide, but I'll just talk over it. But in cardiology, it's also critical to improve patient engagement, and telehealth has really helped us recognize the ability for this platform to achieve those goals. We have tools here, both with the hospital and as an outpatient, such as MyChart, which allows portal integration that, combined with telehealth, can really provide a rapid response and a reimbursed response. That's the key, and a reimbursed response to any questions or concerns. The other piece that I think is so important is that telehealth, we're learning, can provide a multidisciplinary platform for the heart team. And the heart team is critical. So get with the guidelines. There are so many disease processes, so many complex coronary artery disease, structural heart disease. You may be aware of valvular disease, the new TAVR programs and valve programs. The underlying fundamental piece to all of it is the heart team. And the heart team is typically the structural heart surgeon, the interventional cardiologist, the primary care doctor, and the family and patient. And they all will take part in these discussions and difficult decisions. And nowhere before have we had a platform where we could bring all these people together to have that group discussion. And I think telehealth is really the tool for all of those things. Next slide, please. In cardiology, and you can hit the, click it until we get all the nice pictures on the slide here. In cardiology, we're currently looking here at USF into integrating a lot of different venues for our telehealth program. We're looking into the home health visit, which I think is a perfect opportunity where nurses that visit people at home can call, they can do a telehealth visit, an integrated visit, and provide on-site and on-time care for the patient. It's especially important for post-hospital care. We have a large surgical program, a large structural heart program, a large interventional cardiology program, and we have discharges that really would do a lot better if we could perform kind of a home health, telehealth program, certainly within a week or two after discharge. We're looking into remote second opinions, long distance healthcare, and again, we have found tremendous satisfaction in patients that are far away. Next slide, please. And you could click again. Great. And so as I'm running down here to the end, you know, both within our institution and with technologically driven patient engagement solutions, I think, you know, one may say patient will never come to our office again. We've wondered that, we've talked about that, and what's the reason to have a patient come to our office? I'm a cardiologist. I don't wear glasses, although I need them. I am a little bald, you can't see my picture, but I don't bring a stethoscope around. I haven't worn a stethoscope in 5 or 6 years. And it's not that I don't want to listen to people's hearts. It's that in this day and age, we have so much testing. We have echocardiography and on-site and bedside and portable ultrasound of the heart. I promise you, those tests are much better than my stethoscope ever was. And so the only reason I ever used it in the past was to look like a cardiologist. But now that I've gotten older and more mature, I don't think I need to look like anything anymore. I think that telehealth also allows patients to follow up on their own and self-advocate. And they can follow up on their own with tests, follow up on their own with medication changes, routine check-ins. I think telehealth really provides that platform for all of those simple visits as well. And so I think patients are going to become much more self-engaged and self-advocates. Next slide, please. And you can click another click for me. A couple more clicks. You can fill the whole slide because I'm just going to speak through it again. I stole the slide because it caused me to think about, and I stole the slide from the American Heart Association. It caused me to think about a few things. It caused me to think about the transformation and what transformation at Telehealth taught me. First of all, we do not need to see patients in person, which is guideline-directed care. I wonder if the guidelines will change, and I think this is kind of interesting. In the last few weeks and months, we've noticed that there's a trend of lower acute coronary syndrome, lower heart attack rates, patients not coming into the emergency room with acute heart problems. This has been a trend across the nation. In fact, our lab, as well as labs across the country, have found a 40 to 60% reduction in heart attack. We don't know why. It may be several reasons why, maybe multifactorial, but it may be that we're hankering at home, we're not under stress, we're not going out, we're not staying out late, we're not working hard, we're not in traffic, we're not coming home from work after a 15-hour day, and so therefore we've seen a decrease in heart attack. But I wonder if this COVID era has caused a more conservative approach. In other words, likewise, we're not doing stress testing, we're not doing echoes, we're not doing elective testing, we're not doing EKGs, we're not doing physical exams, and yet we're not seeing an uptick or an increase in health disease, in heart disease. In fact, we're seeing a significant decrease during this time. What I find interesting is that during crises in the past, like the flu, or even major earth crises like earthquakes and wartime, there's always been an increase in heart attack, in heart disease, and stroke. This is the first time that with stress, a stress environment, we're actually seeing a decrease in these things, and it's very interesting. So I wonder if the guidelines may change, but the data collection will be key. And so this data collection, I think, will be a nice transition into the AHA's presentations in the future. Next slide, please. So in summary, telehealth for us has been truly transformational. It has redefined our purpose. It has made us take a long, hard look at how we have done things in the past and how we will do things in the future. And it's forced us into new worlds to explore, and I'm certain will benefit cardiology and the healthcare delivery in whole. And I think it's a permanent piece that is here to stay. So at that, I will end, and I thank you very much for your time.
So that was absolutely fascinating, and I think we could all hear stories like this. It just is amazing to me. I hear these hospitals that are really struggling, but it seems that you found some opportunities to overcome the challenge of not being able to provide the normal hospital procedures that people typically have, and which is causing a huge strain on these institutions. I thought that before we move on to Jackie, we would have maybe one or two questions from the participants, if anybody has one. And anyone want to ask a quick question before we move on to Jackie? All right, well, why don't we go ahead? Jackie, oh, hang on a second. Hang on. All right, here's one question before we move on. It's I heard that appendicitis rates dropped significantly, while coronary disease drop made sense as explained. Any insights into other seemingly stable events that have dropped as appendicitis rates?
So if I understand the question correctly, is if acute coronary syndrome rates have dropped, can I extend that explanation to other disease states? Is that the question?
Yes.
So, I read about appendicitis also being lower, but then I read another anecdotal article. Again, this is all fresh, right? So we'll read something tomorrow that may change everybody's answer and everybody's kind of take on what's happening. But I also read another article that there's a higher rate of appendix abscesses. So in other words, patients aren't coming in timely. So they're not coming in on time with their appendicitis, and therefore they're developing an abscess because the appendix is not removed. So they're seeing a higher or an uptick in the number of abdominal abscesses that have never been seen before. It's interesting. One of the folks in cardiology, one of the expert panels that I was listening to and participated in, thought that we're going to have a huge swing of patients that are going to be coming in with terrible heart failure and heart muscle that is just damaged because they never came in with their chest pain or their heart attack when they had it, and they stayed at home. And then the second piece is some feel that there's a lot of patients that are at home with sudden death. In other words, they didn't come in with their heart attack and they had an arrhythmia, a life-threatening arrhythmia, a few days after not coming into the hospital for their heart attack. I'm not certain. Our number that we're looking at is we cover about 4 million patients in the Tampa area, the 4-county area. Our particular hospital has obviously not all 4 million, but we have a good sample of that population. And I can tell you that I don't think that we're getting sudden death increases. I don't think we're getting people who missed the boat, who didn't come in with their heart attack as much as we thought they would. I still think it's just undefined and unclear why we didn't see such a higher level of myocardial infarction. It is possible that people are not coming in with the warning signs and may not getting adequate treatment when they have the warning signs, either of stroke and heart attack. And so we'll just have to see what the data pans out. I mean, your guess is as good as mine. It would be interesting to see if we may not be getting the initial event, but now we're going to get the complications of the missed events later down the road.
Well, thank you. Why don't we go ahead and move on to Jackie? Jackie, you are you're unmuted, and
yes.
And Dr. Berlitz, if you could stay on until the end, if you're not called for any emergency, that would be terrific. So Jackie, why don't we go ahead?
Sounds great. Hi, everyone. I am Jacqueline Tomei. I'm a quality programs manager with the American Heart Association's National Quality and Health IT team. And I'm here to kind of talk to you about what our data-driven solutions are within the American Heart Association, specifically around our Get With The Guidelines program. If you could advance to the next slide. Many people are aware of what the American Heart Association does around our heart walk and our patient education tools and our community impact and youth market. Many people have participated in Jump Rope for Heart or been involved in Heart Ball or our fundraising activities. But there's an entire different other side to the American Heart Association, which is our Get With The Guidelines programs, our interoperability, our work with our professional providers, our advocacy, and work with the clinicians and the hospitals themselves, which is what our Get With The Guidelines programs do. Essentially, our Get With The Guidelines programs are quality improvement programs that can collect data both concurrently and retrospectively at patient level to help hospitals ensure that they are adhering to evidence-based guidelines to improve treatment and prevent future cardiovascular and stroke events. Currently, there are about 2,500 hospitals participating in one of our Get With The Guidelines modules, which basically adds up to 7 million patients that are enrolled in a Get With The Guidelines or entered into Get With The Guidelines. We are looking at the Get With The Guidelines database measures that hospital adherence to prevention guidelines in several different disease states and focuses on working with care team protocols to ensure that patients are treated and discharged appropriately. Next slide. So we have Get With The Guidelines programs in stroke, resuscitation, heart failure, AFib, and coronary artery disease. On the left, there's a list of some of the adherence and some of the metrics that are measured and Get With The Guidelines, but this is just a really small sampling specifically around heart failure, which is my focus. And what we do with our Get With The Guidelines and health IT teams is really to focus on how we can help clinicians access that real-time, hospital-specific, and aggregate data to understand how they can improve, how your hospital can improve, how the hospital can improve, and what we can do to assist the hospital in improving. It's not just, here's a registry, good luck. There are field staff in every state that really work hand in hand with the hospitals themselves and the providers to understand what may be inhibiting that hospital from reaching those adherence benchmarks, and to reduce those readmission rates, to increase adherence to treatment guidelines, and overall improve patient care. Next slide. So as part, when COVID hit, the American Heart Association also decided that, as Dr. Berlitz is saying, this is something that needed to be tracked. And we launched our COVID-19 CVD registry, which is an opportunity for hospitals to track their COVID patients and understand what is happening within the COVID patients that are coming into their hospital, and utilize that data to improve their care and understand what is happening as those patients progress in that disease state as well. And in addition to that, which I'm going to talk about further, we also made improvements to our current Get With The Guidelines modules to ensure that we were tracking what happens down the road when those COVID patients are being treated maybe later on for heart failure, or if there's any indications for COVID-related myopathies. Next slide. So what my specialty is and what I specifically focus on is our Get With The Guidelines. It's called Get With The Guidelines 360. It's a 3-market pilot program focused around improving heart failure systems of care using our Get With The Guidelines heart failure program. So we utilize the Get With The Guidelines heart failure module within 40 hospitals within Chicago, Milwaukee, and St. Louis. And our goal was to bring in these hospitals, within those 40 hospitals in these 3 markets, specifically because they're metropolitan markets with diverse populations. And so that we could help these hospitals break down silos and collaborate together to understand how to improve the heart failure system of care within, the entire, their market, but also as the region. And so part of this project was not only bringing the hospitals together for collaborations, not only working with myself and my counterparts in St. Louis and Milwaukee to collaborate to improve measure adherence, but also understanding the system of care in those specific markets so that we can work with, the primary care providers, the skilled nursing facilities, the home health agencies, and really break down the entire system of care to work with those transitions and improve the entire system and the entire process as a whole for the community. As part of this initiative, we provided multi-pronged provider education. There is the opportunity for that, for the hospitals to track their individual data using Get With The Guidelines, but we've also provided benchmark groups so they can track against the market and against the initiative. Our current Get With The Guidelines tools also offer standard benchmarking opportunities such as all hospitals or regionals, such as the Midwest or the state. And we really do work with these hospitals to analyze the results with them and make sure that they feel that we are supporting them, you know, as consultants and as partners in the process. So this has been, we're closing in on the end of our 2-year grant initiative, and it's been really focused on improving the certain, you know, the entire system, but there's been, especially in Chicago, so much emphasis on how we can establish relationships of trust in a very diverse area, because Chicago is very broken down. We have the South Side and the North Side. The diversity of the area has caused a lot of differences in the data on how we can impact even just the differences between the hospitals, where we're looking at some hospitals that have endless resources versus hospitals that have very limited resources, and working to ensure that those collaborations are successful. And so it's really been important to understand how we can bring those hospitals together to collaborate. Next slide. I kind of just talked through this a little bit, but a really important part of this is also ensuring that we can bring that awareness, those resources, not only within the hospital side, but it's understanding what that means for the patient engagement and those key touch points on their in-hospital journey. So there's that in-hospital, making sure that there's heart failure content for the from the AHA at discharge, making sure that patient has education, ensuring that that patient has a 7-day follow-up appointment and they feel that they are being provided a safety net when they leave, or that nurse, or how we can ensure that there is a opportunity for them to feel cared after once they leave the hospital. And then that ongoing communication, which is really where we've been kind of working now in this new space as telehealth has advanced since COVID. Next slide. And as part of this collaboration, and what's really great about the Get With The Guidelines platform is we are here as boots on the ground staff, as hands-on. And so it's been an opportunity, you know, kudos to everything Michael has done to really boost his hospital hands-on. But with the Get With The Guidelines program, we're here to support our hospitals and make sure that they don't feel like they have to do it alone, especially in some of our low resource hospitals. So we've been able to provide, like I said, the Get With The Guidelines tools. We have updated those elements. Now we have the COVID CVD registry as well. And like that has been one side of it, is just the registries, but we also, and they're not just registries, they're really meant to be data quality improvement tools. But we also have provided an entire arsenal of resources to our hospitals, including, and I have these listed here and I'm happy to share them, the AHA Compendium, which is a collection of videos and articles and many things that can be utilized for patients and providers alike. We've also had, as part of the initiative, weekly collaboration calls for the hospitals, for the 40 hospitals to come together and really just share best practices on how things are going, how they're getting telehealth reimbursed, what's been successful, what's not, especially in the vulnerable population that we see in heart failure and the elderly population, where they might not be comfortable with some of the telehealth modalities. It's been really successful to talk through some of the troubleshooting ideas, and we've been able to provide assisted guidance on how to get telehealth reimbursed and really work with our hospital partners to ensure that they feel supported through this crisis. We've launched a campaign on health emergencies. Don't hesitate to call 911, because we're seeing the same numbers where there's such a reduction, and we are equally as concerned as are these patients sitting at home having heart attacks, having strokes, and we're going to see the repercussions later, which is why we've also added these elements to our Get With The Guidelines tools, because we want to make sure that if that is the case, that we are tracking that in the future, as if those patients were at home, and if we're going to see an uptick later on. There's a healthcare professional forum. Please feel free to use it. This is an opportunity for professionals to collaborate on COVID and your crisis and everything that is going on in your environment with our professional forum, and that's remote, that's virtual. And we also have our newsroom, which is just announcements, and we also recommend that you sign up for our quality newsletter, which is just a weekly announcement of all of the up-to-date information or the latest information on COVID or any of our disease states. I think that's the end of it.
Great.
Wow, Jackie, that was amazing. Al, I'm so sorry. Really fabulous work. I have a couple of questions that people submitted prior during registration, but did anyone have a question that they want to ask before I get started with my list? Hang on a second. Yeah, so yeah, you can put your questions in chat, or if you want to just go ahead and ask right now, unmute your line and ask.
Yeah, hi, this is Edward Dick. Can you hear me?
Yeah.
Hi, so if I may, three questions. In Chicago, are you linking social determinant or social need screening like the NowPow at Rush and others with these programs? Just wondering how you're integrating the social need stress with the blood pressure control.
So we haven't been working with NowPow specifically within our Get With The Guidelines program, but we have metrics within our Get With The Guidelines program that do assess needs. And then we also have been, in Chicago specifically, asking our hospitals to implement a social risk assessment at admission, because that has been such a crucial issue.
And I guess my next question, if I may, on the technology side, are you helping people with data plans? How connected are your clients, patients to the telehealth platforms? How well are they receiving it? Is it working for you all? Do they all have a blood pressure cuff at home?
So we have been working with our hospitals to kind of understand what percentage of patients have blood pressure cuffs at home, and we have been working to see kind of what their needs are and where their data plans. So it has been a little bit, because of this initiative, we've been doing a lot more of our rollout and working with the hospitals to see how we can help them. But we did use some funding to provide blood pressure cuffs in some of our high-risk hospitals and high-risk areas.
So I'd like to actually ask Dr. Berlowitz that same question. Can you please respond to that, how your patients are receiving the telehealth services, and what you're doing with remote patient monitoring?
I'm sorry, I had to step off for just a minute. The question then you're asking is what platform we're using? Is that?
Yeah, I mean, the question for Jackie was like, how are, it's one thing to provide these services. How are your patients actually utilizing them? And one was, are there cuffs at home? I mean, how are you getting blood pressures from patients that are remote?
So there are a couple carriers. So to answer the telehealth interesting piece is that we actually have let's just start with the telehealth electronic media. What we're using to perform telehealth. We have medical students have had a lot of their classes canceled. So now we have a volunteer medical school program where they actually call the patient the day before and they have them learn, they give them a tutorial on how to use their computer and how to perform telehealth if they have a computer or even their phone. And they hand walk them through all of that process. Now, how do we get vital signs and how do we get home monitoring? It's been our practice. There are a couple carriers that actually pay for some of the products, some of the combined Medicare, Medicaid products that will pay for blood pressure cuffs. All blood pressure cuffs currently that are on the market, many of them do heart rate and blood pressure at the same time. That's the first thing. The second thing is we also provide vendors for patients to get ECG monitoring. There's a couple of programs that are, retail, and you can monitor by ECG, your own ECG and your own monitoring. That's important when patients have symptoms. So when patients complain of palpitations, that's when it's important to be able to do their own ECG at home, and then they can transmit that to us. The third is that we have always encouraged and shown patients how to get access to on their own things like the Apple Watch and other watches or blood pressure cuffs that they can buy. We have a recommended list, and they can buy them, and they're fairly inexpensive if their insurance doesn't pay for it. So that's how they get the supplies. Unfortunately, not all the carriers, not all insurance carriers pay for it. They're not that expensive, other than the Apple Watches and the ECG monitoring. But for blood pressure cuffs, for pulse, for activity levels, a lot of that now is being done by things they can buy relatively easy at the store.
Thank you. It's fascinating that, things that we use for just exercise are now being used for, really critical care, like the Apple Watch. I have a question here that someone submitted prior to the call, and it's and I think it can be both for Dr. Berlowitz and Jackie. How have data sources changed with the COVID pandemic?
So we have made not only adjustments to what data sources data elements we're collecting, where we are looking specifically for, we're providing hospitals the opportunity to collect COVID-specific data elements, but we also have made adjustments to our coding instructions to ensure that it reflects the current environment so that it is reflective of telehealth, it's reflective of the time that it takes to put on PPE, it's reflective of those that information as well, and that you can track that. So there is information being entered because of the current environment that we weren't entering before that is probably here to stay.
And Dr. Berlowitz, do you want to add to that?
I agree. I mean, I could just repeat that, but I think all of the data elements have changed. The entire environment of data collection has changed. For us, we for the first time are recognizing the importance of the data collection and data elements. We were very behind in terms of simple things like blood pressure monitoring, simple things like heart rate monitoring, weights. Weight monitoring, which is very, very important, especially in the get with the guidelines and heart failure management. A couple of things that we do have some monitoring that's implantable. And so we do perform a lot of remote monitoring with implantable devices, including heart failure monitoring, but mostly pacemaker arrhythmia management. That hasn't changed, but the first piece has changed dramatically. Secondly, we're also embarking some research and registries development for our COVID patients and COVID cardiac patients. And so I think, we're learning actually what data is important more so than ever before. And so just the sheer recognition of the importance of the patient at home being cared for is a huge transformation in care, at least for us. And I don't think we were by any means on the forefront or leading this race. And so I think it allows us to be part of the race going forward.
Thank you. Here's another one actually for both of you. How are social determinants of health being incorporated into the clinical responses, and how are workflows being designed to do this in a telehealth environment? And Jackie, should we start with you and then go over to Dr. Berlowitz?
So that's been something that's been incredibly difficult, you know, from not just a medical standpoint. And being from Chicago, I've seen it impact everyone, just, you know, sending kids home, trying to, their families trying to homeschool kids on one laptop. And we have a very large homeless population in Chicago. There is quite an impact here of trying to ensure what telehealth entails. Currently, CMS requires telehealth to be a video conferencing platform. And I think we need to really assess that. And the American Heart Association actually has changed our guidance and our coding instructions to allow a comprehensive telephone call to qualify as telehealth, because you're not always going to get a patient that has the capabilities for a video conferencing. And so it's understanding, working with those patients, and especially in the elderly patient population, the high-risk patient population where they are homebound, where we are looking at them being reliant on a caregiver, or if they don't have a caregiver, it's working to find these community partnerships that may be able to help out. And so I think one thing that has been incredibly promising is the strength and resilience of community during this time, is that the amount of people who have stepped up to help out. And I really hope to see that continue, because even in my position of a data consultant and a quality consultant, we have never been at loss working with the hospitals of finding community partners that are helping. And, you know, you look to your left, you look to your right, you'll always find a helper. And I think that's just been incredibly heartening to see. So.
Wow. That is fantastic. Dr. Berlowitz?
I think the whole COVID telehealth movement has transformed in terms of social determinants. It's created, I think, a subset of patients that are actually going to be cared for the first time. I mean, patients that typically can't drive or get to a physician's office, referrals that are rural or a long way away from some expertise, patients that are taking care of children now that there's no school and can't come to the office and can't see a doctor because all the children are home and being homeschooled. Patients that don't need to come to the physician to see an in-person visit, and that's what we're seeing as well. All these patients, I think, have the ability now to get the health care that they need and can actually self-advocate and be part of their health care. They can participate, be engaged much more than ever before. I think, I can't say enough, I know I've said this word many times today, but transformational. I think that this crisis has made it transformational. And even the phone call, the phone, just a simple phone call, calling a doctor's office. We've all had that experience, and it's impossible. None of us is optimistic when we call a physician's office that we're going to get through to anybody, let alone anybody that can answer our question. And now, with the change in rules, the phone call is no longer. It used to be a very small reimbursement. Now, based on time, it can be equally reimbursed as if they had an in-person visit. And I hope it stays that way, because it really is all about the time that you spend with the patient. Sometimes a phone call is the best that a patient can get, because they can't get to a facility, they can't get to a clinic. They don't know whether they need to or not. You know, I think that a lot of people are home wondering whether they need to go to the emergency room. How many all of us wonder, where we have these symptoms, do I need to drive to the emergency room? And especially during COVID crisis, does any of us want to go to the emergency room with any symptoms? And so our threshold bar has certainly changed. But now we can ask that question with our symptoms to a provider that can give us an on-time response where we can either delay or not go to the hospital at that point in time, or go if you need to. So again, I think it's been the idea of social determinants of healthcare being transformed by this COVID crisis. It'll be an interesting future for sure.
That was really what a fabulous answer. So we're really at the top of the hour. So just in closing, Dr. Berlowitz and Jackie, any last thoughts on social determinants of health and cardiovascular disease?
I do just want to add, the American Heart Association, all of our resources are available at www.heart.org/quality. I do believe one of my colleagues put that link in the chat. Additionally, we are offering our COVID registry for free right now. So if you are interested, please feel free to follow up for that information or follow up with me. For any of our registries, I'm happy to provide you any information on any of our registries or any of our resources. We're here to help you. We're here to be your partner. We're here to support you. So, you know, data is going to be incredibly crucial right now and in the future, because it's about tracking what happens and what did happen. So I think if you are interested in tracking anything, please feel free to reach out, and I am more than happy to assist you.
Thank you. Dr. Berlowitz?
Great. Thank you very much. No, I'm just happy to be here. I was happy to be invited. It was fun to talk about this stuff. It's been a big part of all of our lives over the last 6 to 8 weeks, for sure.
Well, you all are doing amazing work. Thank you so much. Al, any last comments?
No, we're over time. Had some great questions. We'll have to save it for next time. Thank you guys so much, and keep up the good fight.
Yeah.
Okay.
Thank you, everyone, and thank you for the participants on the call today.
All right.